Thank you very much for the invite. I just have to say, I think Raul gave most of my talk, so I think I should just go sit down. Uh, but it's a good segue. So I don't have any relevant disclosures to this topic other than the fact that I'm very passionate about this topic. I started our interventional PE program, and we have done about 200 PE interventions in the last 2 years. Okay, good. So as was previously spoken, this is a serious disease. We do not learn enough about it during our cardiology fellowships or during our interventional fellowships, but it's a very serious disease with a serious burden, economic burden, as well as mortality. And it does not discriminate. These are all the famous people who died of PEs. Usual patient, 60-year-old, unprovoked PE, who had basically a high heart rate. Basically he came with mildly low saturations on room air, severely dilated RV on the both imaging studies, echo and CT. Tropes were elevated, so essentially classified as intermediate high-risk PE. So as you know, most of the guidelines are kind of equivocal how to treat these patients. So this was back a few years ago, and these are slides of one of my friends, and at Cedar Sinai. A few years back, they just treated the patient as the guidelines would say, perhaps with heparin. Now we have changed the way we treat these patients. He stayed in the hospital for a couple of days. You see extensive clot burden. Significant RV dilatation we saw, as well as reflux of the contrast into the hepatic vein. He goes home, and as you can see, this is his autopsy. He went home after 4 days of feeling better, and he syncopized after he was trying to defecate, and this is not uncommon. They sometimes, because of the changes in the intra-abdominal pressures, he threw another clot and basically passed away. And this is his autopsy. So that's what we are trying to avoid. And what we are trying to avoid is this progression of rapid RV failure. I do not want to belabor at this point, but I do want all of us to remember that we are trying to intercept this shock spiral. And you guys all know this from medical school, but I think it's a good way to imprint in your mind that this is what we are trying to achieve when we are trying to treat these patients in a timely manner and take them to the cath lab in a timely manner. As was previously alluded to, Raul spoke about this a little bit. I'm just going to try to bring home the point that broadly we classify these PE patients into the 3 classifications: high, intermediate, and low risk. So the low risk patients are ones we mostly don't even get to see because our ED colleagues usually, or our medicine colleagues, see them and discharge them on DOACs. The above 2 are the ones that we have to pay special attention to. So the intermediate class is further subdivided into 2, intermediate, high, and low. So they become intermediate on the basis of certain clinical parameters, as you guys may be well aware of, the simplified PESI score or PESI score. I'll go into that a little bit more. And if they have RV dysfunction or RV injury, meaning enzymes, if they have either of those and a high PESI score, then they're intermediate low. Either one of those. If they have both and a high PESI score, then they're intermediate high. And the high-risk Ps are the ones that Raul spoke about, patients who are in obstructive shock, who have systolics of less than 90, requiring presses, so on and so forth. So why this is important is I'll tell you in the next slide. As you can see, the mortality of these patients it's markedly different. The low-risk ones have a mortality of 1%, and the highest risk group has a mortality of about 30%. So, and the ones in between, they fall somewhere in between. And even in the subgroups, it becomes a little granular because these patients, between high, intermediate, and high-low, even the mortality there goes up significantly. This is a simplified PESI score. I know many of you may be using that in your clinical practice: age, history of cancer, cardiopulmonary disease, systolic blood pressure, heart rate, SATs. And somebody with a 0 PESI score has a 1% mortality, and even if one of these is positive, that drastically increases your 30-day mortality to about 10%. So some of the other prognosticators which are not captured in those two algorithms as I showed you would be a clot burden, the central location of a clot, concomitant DVT because we are concerned that there may be a second hit, and residual pulmonary vascular obstruction after your procedure. So the other thing that I want to bring home is shock index. Shock index is basically the ratio of heart rate to systolic blood pressure. So you may see a patient with seemingly normal blood pressures, but slightly elevated heart rate. Just keep an eye on that patient because they may be teetering towards that shock spiral. And as you can see, it has a good correlation with death. And then this is actually one of the newer scores, and our good friend, Dr. Bangalore, just published this composite pulmonary embolism shock score. And it is basically a few things that RV, both clinical and imaging, that are all combined together. And this has a very high predictive value of how these patients will do RV dysfunction, trope, BNP, residual DVT, central location, and tachycardia. So it's kind of putting all those scores together. So, it has a good correlation with, how the patient's outcomes. And this is another thing I just want to bring home is this class of normotensive shock. So I have seen in my practice, and I believe that the number is probably even more than 30 to even 50%. Some of the patients who seemingly have normal blood pressure, I routinely now do their PSATs, and many a times you'll see that the PSATs of those patients are like 40s, 30s, so meaning their cardiac indices would be somewhere of the order of like less than 1.8, 1.9. If you see the same patient in the context of a STEMI, we will all be super alarmed. But somehow, when we see these patients in the context of a PE, we're not taught to, be proactive about it. But since doing this, I've learned that these sometimes, these patients can be tenuous. Again, the correlation of the shock score with outcomes. Okay, so this just speaks of the guidelines. The guidelines are kind of lagging behind of all the data that Rahul showed before. That the guidelines are somewhat the guidelines we have are basically the ASC guidelines from 2019, and as you can see, they're still talking about lytics and surgical embolectomy, which I honestly haven't seen a surgical embolectomy done at our center in the last 3 years because most of these patients we treat them percutaneously. And the percutaneous treatments is given a 2A classification. And again, the same for the previous slide was for high risk, and this is for intermediate and low risk. Even similar to this, they recommend using percutaneous options or surgical embolectomy in patients who either have a failure to therapy or contraindications to AC. And this is the dose we use of TPA, just for you guys to have. You can use it later, also from the same guidelines. So this is one of the earlier, this is the trial, the PYTHO trial that was published in 2014, which was the initial lytic trial of systemic lytics in the intermediate risk PEs. It randomized tenecteplase plus heparin versus placebo, in which heparin alone was given. And then it looked at the outcomes of these patients. The overall outcomes were actually basically there was equipoise because initially you would see that the hemodynamic decompensation and recurrent PE is better in the tenecteplase arm, but that is sort of overthrown by the risk of bleeding in that arm. So. Yeah, so basically that. And then this was an excellent systemic meta-analysis that was done, which basically showed the same thing, that although mortality and hemodynamic decompensation and treatment escalation can be prevented by systemic lytics, but it is, again, comes at a risk of, which we very well know, of major bleedings. And one of the most feared complications is the intracranial bleeding. If you ask anybody sitting here, we would not want a complication. We would not want a head bleed for ourselves. So why would we want that for our patients? So, so again, this is a paper that everybody should read who is interested in this field. It's Jay Geary's paper. It's basically a summation of all the interventional therapies. It's slightly older, but still a very excellent summarization of the topic. And essentially, it basically goes into what are the therapies that we use in the cath lab as Raul mentioned, this is a very evolving field, and almost every month, if not every 6 months, there's new therapies coming in. So this is the endovascular lytic based therapies, and then we'll talk about the endovascular, large bore thrombectomy based therapies. So this is a summarization of the lytic-based trials, Ultima, Seattle, Perfect, and Optimize. So all of these trials, as previously was pointed out by Dr. Patel, that they looked at the surrogate of improvement, which is the RV-LV ratio. And all of these actually show the same thing, that, lytics given directed lytics, either using the ultrasound or just a catheter-based drip therapy, they lead to quicker resolution of the RV overload. And luckily, as you can see previously in the tenecteplase study, the dosage was super high. It was almost 100. In all of these trials, as you can see, the dose is almost 1/4 of that. So this basically led to, there was no significant, there was only a non-statistically significant increase in the bleeding if you gave directed lytics into the lungs directly. I think it's probably based on the fact that they gave a lesser total dose. The major risk of bleeding is around 4.3, you saw, which is kind of half of the other meta-analysis that I showed you before. And this is again from Dr. Giri's meta-analysis, that it showed that these 6 trials, and it showed the lytic-based, not the systemic lytics, but lytic-based therapies in the cath lab. The risk of bleeding was significantly reduced. But still is there. And then again, the risk of intracranial bleeding is also reduced to 0.7, but it's not negligible. So even 0.7% lytic, intracranial bleeding I think it's a relevant outcome. And now this brings us to what everybody is seeing on Twitter, and everybody's excited about those clot pictures. So I promised myself I'll make a slide without those clot pictures, because I'm sure you guys are all seeing all of those pictures all over. So this is the plethora of the devices we have, and as we know, a very evolving field. We have the Penumbra's device, basically the Penumbra's Indigo system. AngioDynamics has an AlphaVac and an AngioVac system. Again, and the AlphaVac we've previously was used mostly for clots in transit and for vegetations, but now their AlphaVac system we use for PEs, and Inari, which I personally use the most often. And this is Inari I think I would consider this as the predicate device, and this is their first trial that they showed. Basically, it was a safety and efficacy trial, and it was conducted. We were at Lenox Hill. We were a part of the trial, and 800 patients enrolled in about 50 states, and basically looked at the major adverse device-related endpoints, device-related injury or mortality, major bleeding, or interprocedural device-related AEs. So essentially showed pretty excellent outcomes. Major adverse events in 48 hours were, of less than 2%, and the mortality was basically less than 1%. And pretty excellent long-term outcomes, as well as improvement in the immediate clinical endpoints as well. And normally, if you study the PE literature, usually the CTEPH it's about 3 to 5% of the patients who have PE patients, they can develop CTEPH. But if I'm allowed to extrapolate this data, it's even the chances of you actually reduce the incidence of CTEPH if you take the clot out. And overall, very safe, no significant AEs. Now going to this other topic, so the FLASH was basically in intermediate high-risk patients. Now, this is a little bit more tricky when we talk about the high-risk patients, because again, as Dr. Patel mentioned, to study outcomes that are so hard as death, so we would not randomize patients, because you would not allow a patient to die in order to study a trial design that would not work. So what they did was they basically looked at looked at this. This is actually also a very excellent meta-analysis that basically looked at the mortality and complications in all the high-risk. It's basically a systemic meta-analysis that looked at complications and mortality in all the high-risk patients in about 750 articles they identified, and eventually they included 27 of these. And as you can see, this number here is relevant. I'll tell you in a minute why. The in-hospital mortality of these patients, even with the current day practices, although when I say current day, this was mostly lytic-based practices, I should say, it remains of the order of 30%. So based on this number, Inari did their FLAME study, and essentially published, this was a late-breaking trial in ACC 2 years back, and they studied the outcomes of the high-risk pulmonary embolism patients who were undergoing, Inari's flow retriever system versus other contemporary treatments. And this was kind of exciting for everybody to see this because essentially they looked at three arms: the flow retriever arm, the context arm, which was the non-flow retriever arm, any other therapies, which is mostly in this case lytic therapies, and the prior therapy arm, which is what we saw already. The literature, the ones that is studied in the literature, which is about 30%. Again, they studied, this is the primary endpoints and the secondary endpoints: all-cause mortality, bailout to alternate therapies, clinical deterioration, major bleeding. And the secondary endpoints were basically, primary endpoint components plus stroke plus device-related AEs and access site injury, and then hospital resource utilization. So they basically this was stopped early because it met its pre-specified endpoints earlier. So essentially what we see is, as you can see, this is the breakdown of the therapies between flow retriever arm and the context arm. The flow retriever arm, I'll quickly go to this, that composite endpoint was reached in 17% of the patients in the flow retriever arm, and the alternate therapy, which is TPA, this is drastic. You see that 63% of these patients have something really bad happen to them. And the performance goal, as we saw, was 32%. So essentially, the excellent outcomes if you treat these patients early. And the question remains, will it change the guidelines? I think I'm running out of time here, so I'm going to wrap it up quickly. And you guys have access to these slides, so please feel free to use them or look at them. And that is basically, I think most of these some of this is just overlap with what was already discussed. So I just want to show you our algorithm at Montefiore, which is not very dissimilar for what was shown as a Sinai's algorithm. So just leaving this here for you, and if any questions, that's all I have.